Okay, so here we are to finish this up, the last bit of the material for this third exam that you're going to have next week. And I want to talk to you about the eye and the skin specifically. The antimicrobials are in a separate presentation. So this brings us to Unit 8. In reference to the eye, I really want to focus on, in this video, glaucoma. There are some other issues that I discussed in the lecture video. I think I did one or two videos on the eye. So the eye is a pretty interesting area and it's fairly complex. This picture that you're seeing is a cross-section of the anterior portion of the eye. So as you know, the eye is divided into two sections, the front part, which is referred to as the anterior chamber, and the back part, which is referred to down here as the posterior chamber. The point of division between these two chambers is the lens. So of course the lens is the structure in which the light passes through, and it changes shape, and it can focus the light waves on the back of the inner portion of the inside of the ball, which is the retina, and hit those photoreceptors there. But what we want to talk about is the fluid that's produced here in the back. This is called the ciliary body. These are the accessory ligaments that attach to the lens. The ciliary body is where the fluid in the back of the eye called the vitreous humor is produced. And then that fluid travels, kind of squeezes through this little space here, and some of the more mucilaginous or proteins kind of stay back. And as the fluid traverses the from the posterior chamber into the anterior chamber, it squeezes between the lens, and this right here in this view is the iris, which is the colored part of your eye, which is a muscle. And then the fluid fills out this anterior chamber. It's a little thinner in the front, and we call it aqueous humor as opposed to vitreous humor in the back. And then the fluid drains, ideally at about the same rate at which it is produced, and it drains here. There's this like a kind of a meshy tissue called the trabecular meshwork, and then there's a drainage port here, which is called the canal of Schlemm. You may have, since you've taken anatomy more recently than me, they may have given it another name by now, but I learned it as the canal of Schlemm. So what we're moving towards talking about is glaucoma. And glaucoma is an increase in, they say, an increase in intra, meaning inside, ocular, the eye pressure, intraocular pressure. And it's measured by that horrific puff of air that they puff at your eyeball, right? When you put your head in that Chinese torture device. You can tell I don't like that thing at all. Right, and it's measuring essentially how much they puff air at the eye, and they measure how much resistance there is, I guess you could say. And if there's a lot of fluid in there, that would be able to be read. And so the fluid, and with glaucoma, the fluid builds up in this anterior chamber, and it can do damage to the vessels and all kinds of things. So the question is, why is that happening? And there's a couple different reasons for that to happen. One could be you're producing too much fluid, which isn't that common. More likely, you're draining the fluid inadequately. Sometimes it's because this tissue, which is this meshy sort of tissue, it's kind of vascular, and it's influenced by all other sorts of things that influence vascular tissue, like hypertension and diabetes, to name the big top two, diabetes being the top one. Oops, pardon me. So if you can't drain it, you're producing and you're not draining it, then the pressure would build up. Sometimes the iris can get displaced and the whole iris gets pushed, and then it occludes the drainage point as well. So that's a different type of glaucoma, but those are the two most likely culprits for this disorder. So glaucoma is divided into different categories. One is considered wide angle. This is wide angle. And so this, in this picture, right, this is a histology slide. So this is the cornea. This is the iris. This is the ciliary body. The lens would be over here. So the canal of Schlemm would be in this area right in here, the trabecular meshwork. So wide angle is referring to the angle produced here between the iris and the cornea, right? It's like a big wide angle, hence wide angle, versus this one, narrow angle, right? So again, this is the cornea, this is the iris, this would be the ciliary body down here. See how it's squished? This narrow angle has more to do with this iris being displaced and being pushed over. And that is what's causing the drainage issue in this particular case. So there's really three major types of glaucoma. One would be congenital, which we're not going to talk about because that would require surgical correction and outside of the scope of drugs. But then we have primary, which gets broken down into narrow angle. Sometimes it's called acute congestive glaucoma. And again, this issue is due to the poor drainage because of the position of the iris. So what we're going to want to think about with treatment is we're going to want to pull the iris away. So how you can do that is constrict the pupil using our pupil constricting agents, which we're familiar with, and that would help to facilitate drainage. Sometimes you might have to actually surgically correct this. A narrow angle is less common. It's oftentimes unilateral, meaning it's on one side or the other, and it can kind of come and it can go. Wide angle, or sometimes referred to as chronic simple glaucoma, this is again poor drainage, but mostly this is a blood vessel permeability issue. So these are our diabetics, our people with long-standing hypertension, etc. So you can see that they're going to probably need to be on drugs continuously. There's topicals and there's systemics, but most people are treated topically, at least initially. Pupil constriction does help, oftentimes, although these aren't considered the drugs of choice currently. But historically, we have used both pupil constrictors and then also drugs that decrease aqueous humor formation. I'm going to show you a little flow chart to explain this to you. Sometimes somebody can develop a secondary glaucoma. So, and again, like any secondary condition, it's secondary to something else being wrong. So, the big ones are some kind of inflammatory condition that's affecting the eye, like a really extreme allergic reaction. Or oftentimes they've had surgery and therefore like a cataract surgery or potentially like LASIK surgery or something along those lines where they've gotten some inflammation as a result of that. They can also have an infection in the eye which can cause the inflammation, which then can cause the glaucoma. So you kind of have to know what the insult is before you can really treat this, right? If it's just straight up inflammation, then a corticosteroid would be useful, but obviously you don't want to give a corticosteroid because, as we know, those are immunosuppressant agents if there's any kind of an infection present. So you kind of have to know what you're working with, and then your treatment you choose the appropriate treatment based on what the primary condition is. All right, so for both our narrow angle and wide angle, which are considered primary glaucoma, we're going to think about drugs that constrict the pupil. The big one here is our cholinergic drugs, and the sphincter muscle of the eye has a muscarinic receptor there, and so this would be a muscarinic agonist, and an example is pilocarpine. You don't need to remember that name, but it's going to contract the sphincter of the iris, which would constrict the pupil, which would pull it away from the drainage point. It does seem to vasodilate. These do seem to vasodilate a little bit the vessels draining the eye as well, which is helpful. Okay, so especially useful for narrow angle glaucoma because that's where we need to move the iris out of the way. So then we have our drugs that reduce fluid formation. Carbonic anhydrase inhibitors really aren't used hardly at all, only if there's nothing else to use, so we're not going to talk much about that. We could use adrenergic drugs. We have alpha-2 receptors in the radial muscle of the eye, which would potentially be effective here. We have beta blockers, which are more useful for the ciliary body. They decrease fluid formation at the ciliary body. There's beta receptors there. And currently the drugs of choice are called prostaglandin analogs, which decrease fluid formation as well. So here's sort of our flow chart. The drug to, that was it. I did have that wrong on the previous slide. I knew that was wrong. This should not say agonist. This should say antagonist. It didn't make any sense to me. Okay. Okay, that makes way more sense. All right, so here we have our drugs that constrict the pupil. Here's our cholinergic agonist. That's going to be topical and preferred. But then we also have drugs that can affect fluid formation, and in this case also constrict the pupil. So up until recently, beta blockers were the drug of choice. They are really effective at the ciliary body. They kind of leave the lens more or less out of it. They do affect night vision. So that was a bummer about these. People had a hard time driving at night, especially, which was challenging. And then they've, like I said, they've been replaced by these prostaglandin analogs. Those are the new drugs of choice. They're used topically. They have very few side effects, one of which is interesting, and is the prostaglandin analogs cause people's eyelashes to be long and lustrous, so much so that they actually developed a mascara with the prostaglandin analog. I believe they marketed that as Latisse, so not for people with glaucoma, but just for the eyelashes. Sometimes the prostaglandin analogs, I mean, they can cause some irritation to the eye. That's quite common, some redness. People usually get used to it, but initially they can cause some redness. And the other thing they can do is just sort of change the pigmentation of the eye, so they might change the color of the eye a little bit. They might get like little different colored speckles in there, which, you know, is not that big of a deal, but it can be sort of not so desirable depending on what you feel about your eye color, I guess. Okay, so that's it for our glaucoma treatment. So run yourself through those. Again, current drug of choice, which I think this is in your book, but I'm not totally sure. So if it's not, write it in there and remember it. All right, finishing up here with the skin. So these are just terms I would like you to know. An emollient is like a moisturizer, something you put on topically. An antiseptic is something that cleans. It does not disinfect necessarily. It just sort of wipes the dirt around, it seems. So anything that you could use in like, alcohol, betadine, those kinds of things are considered antiseptics with varying degrees of antimicrobial action. A keratolytic is something that's going to dissolve that outer keratin layer of the skin. The utility around this is probably most oftentimes like wart removing agents are keratolytic. And topical corticosteroids. Topical corticosteroids are used all the time for any kind of itchy, scratchy skin thing, right? They're anti-inflammatory. They can be used topically if someone's got a really crazy inflammatory reaction of the skin, like I'm thinking of poison oak, poison ivy, those kinds of things. Oftentimes they're going to have to be used systemically. They're very powerful immunosuppressant agents. A lot of these topical skin things are immune mediated, and so they can be pretty effective. With topical corticosteroids, probably the most common use of these is eczema, which is sort of like asthma in the sense that it's an immune mediated reaction. We consider it an atopic disease. Same with hay fever, but doesn't fit into this context, but that's our other big atopic disease that's quite common. And those things tend to go together. They call it the allergic triad: asthma, hay fever, eczema. You'll find that in families. One parent has one. Usually the kid will have some one of those in the constellation of symptoms or conditions. But they're allergic, immune mediated, and so the topical corticosteroids are used quite frequently. If they're used topically, we don't worry as much we don't worry as much about side effects, is what I'm trying to say, of the corticosteroids, which are side effects of immune suppression. But there's other things like osteoporosis and, a few things along those lines. But one thing we do know when they're being used topically is they can make the skin pretty thin and more prone to breakage. And some of those corticosteroids can get systemically absorbed as well. They don't really do anything to treat the cause of the problem, and in some cases they can cause kind of a pretty significant rebound eczema, which is almost worse than what it was to start with. So that's something to think about with these drugs. But they are used a lot for any kind of atopic skin condition, atopic dermatitis, some sort of allergic, contact dermatitis, eczema, those kinds of things. They're not used for psoriasis. Psoriasis is different than eczema. That's considered more of an autoimmune condition. But that is about it for that. Okay, so the last thing I want to talk about with you is acne treatment. So acne is something that's also quite common, affects all sorts of people across all walks of life. We see acne really commonly in our adolescents when they hit puberty. When, at times of hormone swings, we consider acne pretty common. So adolescent males and females are afflicted with acne frequently. Women get a couple more chances at it around swings in hormones. So pregnancy, childbirth, menopause, you name it. We have lots of opportunities. So acne there's sort of different ways it presents. Sometimes it's just going to be like little red bumps, papules, we call those. Oftentimes there's pus. The sebaceous, so your sebaceous glands in your skin produce sebum, which is kind of this natural moisturizer, which we don't like when we're adolescents, but we're really happy to have when we start to get old and wrinkly, because it moisturizes the skin, right? And one thing that can happen with acne is the duct, right, that leads from the sebaceous gland to the surface of the skin can get plugged by this thick sebum, which seems to be thicker at times of hormone swings. And the oil can get oxidized in there, and it can get infected as well. There's a lot of substrate for bacteria, right? There's a huge amount of bacteria on the skin. It's just like there's a huge amount of bacteria everywhere, right? We've got the skin microbiome, the oral microbiome, the intestinal microbiome. So, it's sort of this perfect storm of these things happening. More oil produced, maybe getting thicker, maybe plugging the duct, and then maybe getting infected. And then if it does get infected, then we get these sort of deep cystic lesions. So the presentation is variable and the treatment's different based on what kind of acne you see. So we're going to start with topical and some over-the-counter stuff. So the ingredients that are useful for topical treatment are salicylic acid, benzoyl peroxide, antibiotics, and topical retinoids. So salicylic acid is pretty well tolerated, and it's just a topical keratolytic. So basically what it can do is it can kind of take away some of that top keratin layer, and also sometimes help to open up that duct so the sebum can drain better. Benzoyl peroxide is an antimicrobial agent. It is bactericidal, meaning it kills a specific bacteria called the Propionibacterium acnes, which is this one that we blame acne on, although I think there's probably more to it than that. But that's one topical skin bacteria that plays a role here. It's not abnormal. It's supposed to be there, but when it's mixed with all this other, when you line it all up for this sort of perfect situation, that bacteria, feeds on the oil, and then it's really happy, and then it plugs the ducts, and you get the pus, and on it goes. So benzoyl peroxide can be found in over-the-counter preparations, and also in prescription preparations. And again, oftentimes you'll see combined with salicylic acid, and it seems to be pretty effective against mild to moderate acne as well. Then we can use a broader spectrum against more skin bacteria, and we can use these topically, and they oftentimes are recommended systemically. We'll see on the next slide. The topical preparations are usually some form of clindamycin and erythromycin. Those work pretty well topically. They're fairly narrow spectrum, which is good, and they also, interestingly enough, have an anti-inflammatory property. A lot of antibiotics we're finding have anti-inflammatory properties, which is probably why people feel better when they're taking antibiotics, even if they don't necessarily really need them, because it's helping with the inflammation from the viral infection or whatnot. Okay, finally here on our list are the retinoids. They can be used topically and internally, but here we're talking about them topically. They are useful for both inflamed and non-inflamed lesions. They're keratolytic. They kind of sort of take that top layer of skin off. They regulate skin growth and skin turnover, and that's nice. They are sometimes used for aging skin as well for the same reason. The thing about retinoic acid topically is, and systemically for that matter, is it can dry the skin out. It can cause the skin to get really dry, scale. It makes the people real sensitive to the sun, and that's something to be aware of. Redness, burning, itchy skin, all of those are really common with retin-A. Traditionally, if you start with a real low potency one and you kind of just use a little bit and sort of build up, it works better for the acne, but it can be quite effective topically. Of all of these, probably the most effective topically. And then finally, if that doesn't work and we're getting more from the mild to moderate to severe acne, then we have to start thinking about pulling out the bigger guns. Systemic acne treatment usually revolves around oral antibiotics. Again, we think of this being kind of an inflammatory acne, somebody who has a lot of pustules. You kind of think about bacteria when you have that. Tetracycline is a commonly used drug for systemic acne treatment, which is a very broad spectrum drug, and people tend to be on this for a really long time, which is kind of detrimental in the long run, depending on your opinion of this. But it's a broad spectrum drug, and we really caution people for using very broad spectrum antimicrobials for any length of time because of this resistance issue, which you're going to learn about in all the coming videos on antimicrobials. However, they do still use it. There's a combination medication now, which is a combo of both the tretinoin, which is a retinoic acid, and clindamycin, which is an interesting combo for the inflammation and the infection. When you're using oral antibiotics, you got to think about superinfections, which is another infection that's due basically to the wiping out of the good flora, which will happen with a drug like tetracycline. And the other thing that's really important to know, especially when we're thinking about the climate of the patient that are oftentimes being treated for systemic acne, I'm thinking mostly younger women here, is that they need to know that it's down there at the bottom. Let's look down here for a second. So another real useful treatment for women is and acne is oral contraception. Oral contraceptives raise sex hormone binding globulin, and essentially they decrease free testosterone, because the more sex hormone binding globulin you have, the more sex hormones bind and the less free hormone there is. And free hormone is an issue with acne, and so oral contraceptives can be pretty effective. And sometimes girls are on oral contraceptives for girls and or women for their acne, and then they're also administered an oral antibiotic for the same reason. And they need to know that the oral contraceptives are not going to be as effective, or maybe completely ineffective, with the oral antibiotic on board. So that is something that we really, really need to make sure we let people know, because that would be a huge disservice if people didn't know that the oral contraceptives were no longer being useful for contraception when they're taking an oral antibiotic. Okay, the big gun here is isotretinoin, historically called Accutane. Sometimes it's called cis-retinoic acid. This drug has been pulled from the market by the name of Accutane, but you can still get it. The reason why it has been, well, it's got all kinds of issues. One big one is that it's hugely teratogenic. So you have got to be sure that your patient is not going to get pregnant. They have to sign forms, and they have to take pregnancy tests, and you as the prescriber have to make sure that you are telling them, and you have to sign forms. It's a big deal. There's a program you can see down here regulated by this iPledge program. That's a risk management program to prevent fetal exposure. And you can see 2 negative pregnancy tests and a statement of understanding, knowing that it's a huge teratogen. So really, really dangerous drug if a person gets pregnant while on isotretinoin. That being said, the drug is incredibly effective against acne. It drastically reduces sebum production. It's a huge keratolytic and an anti-inflammatory. So this is definitely the big gun. However, there are all kinds of side effects, ranging from pretty minor to, well, not really minor, incredibly dry skin. But they can lose hair, they can develop eczema, their skins get really fragile and friable. Super sensitive to the sun. They'll burn in moments if they're out in the sun. They can get migrating muscle aches, increased blood triglycerides, which is strange and usually shows that there's something going on with the liver. Also sometimes blood lipids. Makes me think that there's some damage happening to the liver. It can cause acute hepatitis, pancreatitis. It's been linked to irritable bowel syndrome. There at one point was a class action suit actually in that regard. So I don't know about that. Seems like a risk. However, it does make the skin look really nice. So the verdict's out on that. You can see these are some of the other names that it is sold by now that Accutane, I believe, is not available by that name. So I think that's it for systemic acne treatment. So you would ideally start topically and then move to the systemic, and again reserve that isotretinoin to the severe cystic, deep cystic lesions. This is not for just like a couple pimples here and there. It's way too big of a gun for that. All right, so that is it. You guys are wrapped up for your next exam, which is going to be, if you're in the summer class, it's going to be on Monday. We're going to do a review session on Friday. It's looking right now like it's going to be at 5 o'clock. It's going to be virtual. We'll work that out. It will be recorded. If you have questions and you can't be present, email me your question or post it to the discussion board. If you're going to come with questions. That's kind of how we're going to do it. I'm going to entertain questions and do my best to guide you in that department. Your third exam is going to cover the central nervous system, Unit 6, Unit 7, and Unit 8, just up to the skin. The other portion is accessible now as well, and that's the anti-infective portion. The anti-infective videos are posted already. I believe there's 3, there might be 2, and there'll be a Canvas test in the same folder as Unit 8. There's an assessment, like a regular unit assessment, and then there's a Canvas test. That one you're going to only have one attempt to take, and you have an hour to do it, which is more than enough time. So just make sure you're ready to go when you sit down to do it. You can't stop and start. All right, you guys. Tomorrow is the 4th of July, if you're watching this on Monday or Tuesday. So enjoy your holiday, and I will talk to some of you on Friday and see the rest of you on Monday. Have a good week.